My name is Katira Noviello Kapoor, and I am the Senior Director of Health Promotion, Wellness, and Athletics here at the 92nd Street Y. Thank you so much for joining us for an evening of learning about cervical cancer education as well as prevention with Dr. Wright, who I will get to introducing very shortly. I did want to let everyone know that this initiative is brought on by a new initiative at the 92nd Street Y called Spark Your Health. So you should see emails coming from myself with lots of upcoming programs related to health and wellness topics. So we hope that you will join us for future programs such as feng shui and sound bathing and meditation. The list goes on and on. I'll send some of them in the chat. And this is also in collaboration with our Himan Brown Senior Program as well. So we're very appreciative to them for all of their help. And with that, Elizabeth, I will turn it over to you to give a brief introduction. 1 second, there we go.
Hi, everyone. I'm Elizabeth Tarr. I'm the Associate Director of the Himan Brown 60 Plus program here at the Y. It's such a pleasure to do these talks for you and bring you great health information and do it in conjunction with Katera and her department. I want to say a big thank you to Dr. Wright for being with us tonight. And I want to say a really big thank you to my very longtime colleague and friend, Karen Schmidt, who's a wonderful nurse and public health advocate and teacher, and has helped me teach people about health-related issues in many settings. So Karen is the director of the Manhattan Cancer Services Program at New York Presbyterian Columbia Medical Center, and she just connects us always with the best doctors who really teach us and help us learn. So thank you both.
Absolutely. Thank you for that, Elizabeth, and thank you, Karen. These really have been a treat and have been so informative, and I will put this in the chat as well, but we do have a skin cancer educational event coming up in May, so I will send that as well. And just a few housekeeping notes. If you do have questions, which we absolutely encourage, feel free to be typing them into the chat, and I will help moderate and get those questions over to Dr. Wright, or we will leave time at the end of the event should you want to unmute yourself and ask a question that way. All right. So with that being said, I'll bring Dr. Wright into the focal point here. So it is my pleasure this evening to welcome Dr. Wright to be speaking with our 92nd Street Y community. Dr. Wright completed residency and a fellowship in gynecologic oncology at Washington University in St. Louis. He is board certified in obstetrics and gynecology and gynecologic oncology. Dr. Wright is currently Chief Gynecologic Oncology Officer at Columbia University and New York Presbyterian Hospital. Dr. Wright is a nationally recognized expert in the treatment of gynecologic cancers and gynecologic surgery. A major focus of Dr. Wright's work is the delivery of quality care to women with cancer and the improvement of outcomes of women with cancer and those who undergo surgery. Dr. Wright is a member of the Society of Gynecologic Oncology, the American Society of Clinical Oncology, and a fellow of the American College of Obstetricians and Gynecologists. So Dr. Wright, welcome. Thank you so much for being with us this evening.
Great, thank you so much. I'm going to share my screen. Can everyone see my screen? Is that coming up? Wonderful. Well, thank you so much. Before I get started, I want to thank the 92nd Street Y, Katira, Elizabeth, for promoting this talk and this topic, and certainly Karen Schmidt for connecting us. I've had the fortune and pleasure of knowing Karen for many years, and she has works tirelessly to bring cervical cancer screening and cervical cancer prevention to our community. So this is a topic I think that's near and dear to all of our hearts, cervical cancer and human papillomavirus. So what I thought I would do tonight is start out and speak a little bit about human papillomavirus, or HPV, and what this virus is. It is the major cause of cervical cancer. So I'll spend some time speaking a little bit about cervical cancer and some of the statistics around cervical cancer. And then I really want the bulk of the talk to be about prevention of cervical cancer cancer and specifically HPV vaccines. And what I'll show you is that cervical cancer is a disease that is within our power to essentially eliminate within the United States with screening and vaccination. So I really want to highlight the HPV vaccines that are available. I'll go through some of the data about the use, the safety, and the indications for these vaccines. And again, as Katira mentioned, there'll be plenty of time for questions. So I really encourage everyone to ask any questions that they have throughout the talk. So what we'll be focusing on tonight is human papillomavirus or HPV. The picture on this slide is an electron micrograph or a microscopic slide of an HPV viral particle. And HPV is important because HPV is essentially a necessary cofactor for the development of cervical cancer. So nearly 100% of cervical cancers are caused by human papillomavirus. So for all intents and purposes, you need HPV to develop cervical cancer. When you look at the association between HPV and cervical cancer, this relationship is stronger than even smoking and lung cancer. To develop cervical cancer, you really need to be infected with HPV and have had an HPV infection. We also know that HPV is extremely common. It's a sexually transmitted disease or sexually transmitted infection. And it's the most common sexually transmitted infection in the United States and worldwide by far. And we'll go through some of the statistics and some of the data around that. So what we know about HPV is that this is a virus. It's a small, what we call double-stranded DNA virus. And on the middle picture on this screen is what we call the genome of HPV. And HPV is made of makes a number of proteins that cause disease and cause cancer. And it produces a number of proteins, what are called the L1 and the L2 protein, which are the outer shell of HPV. And these L1 and L2 proteins are going to be very important when we talk later on in the talk about prevention and the HPV vaccine. Now, human papillomavirus is not just one entity. There have been over 200 separate and unique HPV viruses that have been identified, and there are more HPV viruses that are being identified every day. Most of the HPV viruses infect the outer skin, or what we call the epithelium, anywhere on the body, so on the skin and for our purposes in the genital tract. And these viruses are classified based on the risk in which the virus it can cause a cancer or precancerous condition into different groups. So broadly, there are two large groups of HPV viruses, what we call the high-risk HPV viruses and then the low-risk HPV viruses. And the high-risk HPV viruses are probably the viruses types that get most attention because these are the HPV viruses that cause cancer. Again, importantly, cervical cancer, as well as a number of other cancer types that I'll show you. But on this screen, you can see a listing of all the high-risk HPV viral types. The two most common HPV viral types are HPV 16 and 18. And these are the two HPV viruses that are responsible for approximately 70% of cervical cancers. So a very high number of cervical cancers are caused by HPV 16 and 18. The low-risk HPV viral types are listed in the bottom row of this table. And these are viruses that are not associated with cancer, but they're typically associated with genital warts, or what medically we term condyloma. And you can see a listing of the low-risk HPV viral types. The most common low-risk HPV viral types are HPV 6 and 11. And when we talk about the HPV vaccine later on in the presentation, what you'll see is the HPV vaccine is a combination and provides protection against a number of different HPV viral types, including the high-risk viral types HPV 16 and 18, as well as the low-risk viral types HPV 6 and 11. Now, HPV is associated with a number of different cancers. And you can see on this slide the HPV-associated cancers. In women, the most important HPV-associated cancer is cervical cancer, where again, the vast majority of cervical cancers are either directly attributed or to HPV, or HPV in some way contributes to the development of the cervical cancer. HPV cancer overall, the most common HPV cancer overall, when you look at men and women, is oropharyngeal cancer, or cancer of the head and neck, cancer of the tonsil region, in which there are over 20,000 cases each year. Again, this is much more common in males, where there are over 16,000 cases of oropharyngeal cancer each year, and this number is rapidly rising. So there's definitely an epidemic of oropharyngeal cancer in the United States. HPV is also associated with other cancers of the female genital tract, including vulvar and vaginal cancer, and it's associated with cancers that are unique to the male, including penile cancer. And then in both males and females, it's associated with anal cancer. And again, all of these cancers, what they have in common is the HPV infects the epithelium, either of the cervix, of the oropharyngeal region, of the anal canal, and that can ultimately lead to the development of cancer if the body does not clear the HPV infection. So this is a little cartoon about the way that HPV infection works and occurs, and what I've been talking about. On the left-hand side of the screen is a schematic of the uterus, and the lower portion of the uterus is the cervix, which you can see outlined here. So what happens is the HPV viral particle, it infects the surface covering, what we call the epithelium of the cervix. And the epithelium is the picture on the right-hand side of the screen. So what happens is the HPV infects the epithelium, what's called the basal epithelial cells. And if the body's own immune system does not get rid of the HPV infection, the HPV can proliferate in this epithelial tissue until it essentially fills the entire epithelium and penetrates through what's called the basement membrane, which you can see on the very bottom portion of this screen. And once these cells penetrate through the basement membrane, that's what we classify as a cancer or a malignancy. So HPV infects this epithelium, grows and proliferates and causes precancerous changes in the epithelial layers. And then if it's not ultimately detected or treated or taken care of by the body, it can ultimately develop and form into an invasive cancer. So this is the life cycle of HPV, or what we call pathogenesis of cervical cancer development. And as I said, and I'll show you in the next slide, HPV is extremely common. So we know HPV infections are very, very common, but overall cervical cancer and other cancers are relatively rare. So what happens with most men and women once they have an HPV infection, it follows the top portion of this slide. It's what we call a transient infection. So the body's own immune system essentially attacks the HPV, it kills the HPV infected cells, and it eradicates the HPV disease before there is even any disease, much less a cancer. So in the vast majority of people who have an HPV infection, what happens is this top pathway where the body's own immune system eradicates and clears the HPV infection. Now, in some people, and again, we have a very poor understanding of why this is, the HPV is able to persist in the body. And if you have a persistent HPV infection, the longer the HPV infection persists in the body, it can lead to consequences. And those consequences are first what we call dysplasia, which is a precancerous state. So the HPV persists, it can cause first a low-grade precancerous dysplasia. If it's still untreated, it can cause a high-grade precancerous dysplasia or dysplastic condition. And ultimately, if it's not detected and it persists, it can turn into a cancer. Now, what you can see on the bottom portion of this slide, this is a long time frame from an HPV infection to the development of an invasive cervical cancer. So on average, the time from HPV infection to the development of a cancer is well over 10 years. So there's plenty of time for screening tests. There's plenty of time to detect these precancerous conditions where they are still highly treatable and before they develop and turn into an actual cancer. Now, as I said, HPV infection in the population is extremely common. And overall, when you look at most males and females, most people at some point in their lifetime will be infected with at least one HPV infection. And most people will actually be infected with multiple different types of HPV infection throughout their lifetime, one or multiple of those 200 separate types of HPV infection. You can see that the statistics here, I think really, staggering to some extent. It's estimated that nearly 80 million Americans are currently infected with HPV. There are over 14 million new infections in the United States, extremely common. And we know that the most common age group for people to develop HPV infection is in teens and early adolescence. And as I showed you on the prior slide, the majority of people who have an HPV infection have a transient HPV infection, and the body's own immune defense systems clear the HPV infection before it leads to either a precancer or a cancerous condition that we could detect. As I said, HPV is predominantly transmitted sexually. So it is a sexually transmitted virus. It is a sexually transmitted infection. So it's transmitted by intercourse. And for this virus, this is a virus that tends to be very efficient at being transmitted. So it's highly infectious. This is a graph. This is a graph of female adolescents with one sexual partner. So just with one sexual partner who has an HPV infection, that you can see over time by between 2 and 3 years of just having one sexual partner that's infected with HPV, your risk of developing and having that HPV infection transmitted to you is approximately 50%. So this is a highly infectious virus that is transmitted relatively easily through sexual intercourse. This is another graph showing the cumulative risk of HPV infection with only one sexual partner. And again, the risk of infection with this graph is meant to show the risk of transmission and infection is much younger in younger boys and girls. So in teens and adolescents, your chance of acquiring an HPV infection, if you do have intercourse with someone who's HPV positive, is much greater. And I think the other important thing to note on this graph, when you take a look at the two lower lines, those are the precancerous conditions, what we call a low-grade dysplasia or L-cell or high-grade dysplasia H-cell. And what you can see is where there definitely is a real risk of developing these precancerous cervical conditions in female adolescents. It's much less common overall than the development of an HPV infection. So again, the vast majority of HPV infections are just transient infections that the body is able to clear. This is another graph, again, just showing a little bit about the epidemiology and the prevalence of HPV. And you can see these very high rates of HPV prevalence in the US female population. Again, the highest prevalence tends to be in late adolescence for young women who are in their early 20s, where really the risk of an HPV infection is extremely high overall. Again, we do see not an insignificant number of precancerous conditions associated with HPV, but again, by far and away, the most common outcome of HPV is to have a somewhat transient infection. And then this is a graph that I like to show, looking at the burden of HPV and HPV-related disease in the US population. So again, I think from a cervical cancer standpoint, certainly cervical cancer is the very tip of this pyramid or the tip of this iceberg, where we have around 10 to 12,000 new cases of cervical cancer each year and around 4,000 deaths from cervical cancer. But it's really, I think, the lower part of this iceberg, I think, really shows you kind of the frequency with which some of these HPV-related diseases are diagnosed. So there are over 1.4 million new cases of low-grade cervical dysplasia, over 1 million cases of new cases of genital warts each year, over 330,000 new cases of high-grade cervical dysplasia or precancerous conditions. So all of these precancerous conditions, when you look at the population level overall, these are fairly common. These are common problems in young women and women throughout their lifetime. And these can lead to significant burden of disease and also significant financial burden. You can see here that overall there are 3 million new cases of some of these HPV-related cervical diseases each year in the US, and this accounts for over $7 billion in healthcare spending. So certainly this is a very important problem to women throughout their life frame. So go back to this slide and make one last point about HPV before we start talking more about cervical cancer. But again, I think that the important point of this slide is in the lower portion of the slide. For those women who do develop persistent HPV infections, again, I highlighted this before, the time frame from an HPV infection to an invasive cervical cancer is 10 years. So this is really from a cancer screening standpoint. This is really an ideal scenario where you have this long precancerous phase before the ultimate development of cancer. And we really rely on these detection of these dysplasias, low-grade and high-grade dysplasia, as the way that we screen for cervical cancer, where we can detect these precancerous changes, and then we can go in and eradicate these precancerous changes prior to the development of cervical cancer. And now we have very good screening tests. And again, I'm not going to spend too much time on the screening test for cervical cancer, but now the PAP test and as well as HPV testing, or a combination of HPV testing and PAP testing, are now commonplace for women throughout their lifetime for the early diagnosis of cervical cancer. This is a picture on the right-hand slide of the screen of George Papanicolaou, who was the inventor of the Pap smear. And you can see him in his hand holding a slide. The way that the Pap smear works is the Pap smear is a collection of cells from the cervix that we examine under the microscope to try to identify and find these precancerous conditions. So we're going to turn our attention just a little bit to cervical cancer now, and talk a little bit about kind of the current state of cervical cancer and the treatment for cervical cancer. As I showed you, among women, cervical cancer is the most common HPV-associated cancer. You can see the statistics here. Worldwide, cervical cancer is very common. There are over 500,000 new cases of cervical cancers diagnosed each year, nearly 300,000 deaths from cervical cancer, and these are probably undercounted because many regions where cervical cancer is prevalent keep poor statistics on cases and mortality from cancer. But in the United States, again, where I'll show you cervical cancer is an entirely preventable disease, we still have nearly 15,000 cases of cervical cancer and 4,300 deaths in women attributable to cervical cancer each year. So again, this is a cancer that's preventable, yet more than 10 women die each day in the United States from cervical cancer. Cervical cancer tends to have a bimodal peak, so it can occur in younger women and in adolescents in their 20s and their 30s, and it can also occur in a second peak in older women in their mid-60s. So you can see here, over a third of cervical cancer occurs in this younger population, women who are less than 45 years of age. So a significant burden of cancer in younger women. Now, fortunately, because of the screening test that I showed you, predominantly the Pap smear, the burden of cervical cancer in the United States has been reduced greatly. So this is data on cancer statistics in the United States from the 1930s to the 2000s. So cervical cancer used to be categorized along with uterine cancer. And you can see back in 1930 in the United States, cervical cancer is the most common cancer in women in the United States. And fortunately, that line has gone down, consistently gone down over time as we've been able to widely introduce the Pap smear into screening programs in the United States and get women to have their Pap test with their gynecologist or with their healthcare provider. Now, unfortunately, with the Pap smear, again, I showed you there's been a dramatic decrease in the incidence of cervical cancer in the United States. But unfortunately, we've stagnated. And I think you can see this pretty clearly from this graph. From the mid-2000s on, before that time, we're really making, progress in reducing the incidence and the burden of cervical cancer in the women who are being diagnosed and dying from cervical cancer. But we've really, stagnated going forward. And you can see this line from the mid-2000s on is certainly flat. So there's, as this slide shows, we can do better. We can get this line to continue to go down because there is good screening. There are also good ways to prevent cervical cancer. This is a graph of cervical cancer incidence worldwide. So the areas in blue have lower incidence of cervical cancer. The areas in red in particular have a higher incidence of cervical cancer. And what you can see is areas like Africa, South America, areas of Asia, of Southeast Asia in particular, have higher incidence of cervical cancer. And this is predominantly due to the fact that screening and prevention are not routinely available in these regions for cervical cancer. But, unfortunately, even in our own backyard, there are a lot of disparities in cervical cancer incidence and mortality. This is a heat map looking at the disparities of cervical cancer incidence in New York City. And what you can see, the areas, the darker areas in blue and purple have lower incidence of cervical cancer. The areas in yellow have a higher incidence of cervical cancer. On the right-hand side in figure B is really a map of socioeconomic status. So really, if you overlay these two maps, what you see is areas that with higher socioeconomic status and higher median income have a lower incidence of cervical cancer. And these findings are pretty dramatic. You can see in the example in the bullet points between Sheepshead Bay and Brownsville, distance of only 6 miles. In one area, that the incidence of cervical cancer is more than 3 times higher than the other. So still, even this isn't just a problem in Southeast Asia. This is in our own backyard. We have dramatic disparities in the incidence of cervical cancer. When we look at cervical cancer, most cervical cancers start on the very outer portion of the cervix, what we call the ectocervix. And if the cancer is not detected, it spreads, and it can spread to the lymph nodes, and then it can go on to spread anywhere in the body. But there is a window in early stage cervical cancer when the cervical cancer is confined to the cervix. This is something that's now highly curable. For women with early stage cervical cancer, the treatment is typically surgery. We typically perform an operation called a radical hysterectomy. And that's illustrated on the figure on the left-hand side of the screen. That's an operation in which we go in, we remove the uterus, and we remove all of the surrounding structures to try to eliminate any adjacent cervical cancer. For younger women who have not completed childbearing, we sometimes can do an operation called a trachelectomy, where we just remove the cervix, and we're now able to preserve the uterus. So young women with cervical cancer can go on to become pregnant and to bear children. For those women who have more advanced, what we call locally advanced cervical cancer, the treatment tends to be fairly intense. The treatment is typically radiation. We do 2 types of radiation: external radiation, and then we also do treatment with internal radiation, where radiation source is placed right next to the cervix to deliver a high concentration of radiation to the cervix. And we typically deliver chemotherapy along with radiation. This is a slide of a number of really landmark studies in cancer that show that the chance of curing cervical cancer was higher if patients who were receiving radiation received the radiation in combination with chemotherapy. So now we routinely prescribe chemotherapy along with radiation treatment for those women with locally advanced cervical cancer. This is a slide showing the outcomes and the long-term survival with cervical cancer. And again, what I want to point out is for those women who are diagnosed with early stage cervical cancer, stage 1A, stage 1B cervical cancer, outcomes are very good. So there's still a very high likelihood that the cancer will be cured with the treatments that are available. So even for women with symptoms and a frankly invasive cervical cancer, detecting the cancer early will increase the likelihood that the cancer can be cured. So now I'm going to spend the next 15 minutes or so, the last portion of the talk, really talking about prevention of cervical cancer. And prevention of cervical cancer really relies on human papillomavirus vaccines. Again, I think when you look at cervical cancer, as I told you, you essentially need HPV to develop cervical cancer. So because of that, this is a great target to be able to prevent a cancer, to prevent this virus, to prevent the HPV virus. And we now, since 2006 in the US and worldwide, we now have a number of different vaccines that are targeted towards HPV that are highly efficacious. Now, in the United States, the vaccine that's currently available is what we call the Gardasil 9 vaccine, or the 9-valent vaccine. And this is the vaccine that specifically provides protection against the 9 most common HPV viral types. And you can see them listed here. It's the low-risk viral types, HPV 6 and 11. And it's the high-risk viral types, HPV 16 and 18, and the others, including HPV 31, 33, 45, 52, and 58. So the currently approved vaccine is the 9-valent HPV vaccine. Previously in the United States, there was a bivalent vaccine that protected against HPV 16 and 18, and a quadrivalent vaccine that protected against HPV 6, 11, 16, and 18, but those vaccines are no longer available. The way this vaccine works is this is what's called a virus-like particle vaccine or a VLP vaccine. And you can see that the cartoon on the right-hand side of the screen. The way the virus is produced is that the DNA that codes for the outer surface of the HPV viral particle, what's called the viral capsid, is inserted into yeast or some type of other cell, and then these cells produce the outer capsid of the HPV virus particle, and then we harvest and we can inject that capsid to induce an immune response. Now, the important point of this is that this virus does not contain the HPV DNA that actually causes disease. So the HPV, the part of the HPV genome, the part of the HPV DNA that causes cancer, that causes precancerous changes, that's not actually a part of the HPV vaccine. The only thing that's a part of the HPV vaccine is the outer shell or the capsid shell of the HPV virus. So we inject this shell, the body's immune system, generates an immune response to this HPV viral shell, and that's what provides protection against HPV-related disease. The virus is administered by an intramuscular injection. The HPV virus particles are produced in yeast proteins, and they contain aluminum to help boost the body's immune response. And as I'll show you, the HPV vaccine is now approved for patients, either males or females, who are aged 9 to 45 years of age. So these are the current CDC recommendations. And again, these have changed a lot over time over the last 15 years, but now it's actually much simpler than it was. The vaccine is approved for anybody, male or female, 9 to 15 years of age. Now you can see on this slide some of the caveats and the specific recommendations for HPV vaccination. The ideal time for HPV vaccination is for males and females who are 11 to 12 years of age. So it's approved all the way down to 9 years of age, but we try to vaccinate males and females at 11 to 12 years of age. So this is, in general, this is considered an ideal time because it's typically before the time of first sexual intercourse in boys and girls, and before the possible exposure to HPV. So we want to vaccinate before you've been exposed to HPV to try to generate that immune response and protect against any HPV-related infection. Now, for people who are past that 11 to 12 years of age, but up to 26 years of age, we recommend what's called catch-up vaccination. So we try to vaccinate anyone up to 26 years of age, and we routinely recommend in males and females up to age 26 that we do catch-up vaccination. For patients who are older, either males or females who are older, who are in that 27 to 45 year window, we don't specifically recommend vaccination, but the vaccine is approved and you can consider being vaccinated. And we'll talk a little bit about that discussion in the last few slides of this talk. And the vaccine is not routinely licensed for patients who are over 45 years of age. Typically, the vaccine, the way that it was tested initially was for a 3-dose schedule. So patients receive the first dose on what's called time 0. You come in 1 to 2 months later for a second dose, and then you receive the third dose 6 months after that. So the 3 doses are administered intramuscularly, typically in the arm over a course of 6 months. Now, it has been tested, and now it is approved that for some people we can do a 2-dose series as opposed to a 3-dose series. So the initial recommendation, this is now getting expanded, is that for those people who receive their first dose prior to their 15th birthday, instead of 3 doses, you only need to receive 2 doses. So you get the first dose, and then you come in 6 to 12 months later for the second dose of the vaccine. So either a 3-dose or a 2-dose series, depending on the age at first vaccination. If the series is interrupted, you don't need to start over. You just need to complete the series. We don't need to do any pre-testing. So you don't need to test for HPV or HPV antibodies prior to vaccine. Really, the only criteria for whether or not you can receive the vaccination is the age. And if you fall within that age for vaccination, you can undergo vaccination. For those patients who already have an underlying HPV infection, either warts, a cervical precancerous change or abnormality, the HPV vaccine does not help eliminate that HPV infection. The HPV vaccine is purely meant to be prophylactic. So again, that's why the recommendation is to start at 11 to 12 years of age before exposure to HPV. There have now been multiple large-scale medical trials looking at HPV vaccination, comparing outcomes of people who've been vaccinated versus those who've not been vaccinated, again, both males and females. And what we see continuously across all of these studies is the vaccine is highly, highly efficacious. So in most of these trials, near 100% efficacy against in preventing these high-grade precancerous changes that are caused by the specific HPV viral types that are part of the HPV vaccine. So again, highly, highly efficacious. And what we also have seen in these trials is if you have been exposed to one of the HPV viral types in the vaccine, that doesn't seem to blunt your immune response against the other HPV viral types that are in the vaccine. So again, any exposure to any of these viral types in the vaccine tends to elicit a long-acting immune response in people that's highly efficacious in preventing infection from the relevant HPV viral types. In general, the vast majority of people are candidates for the HPV vaccination. You can see the contraindications on this slide to HPV vaccination. So if you have a severe allergic reaction to a component of the HPV vaccine, so this in large part is either to yeast or aluminum. If you have hypersensitivity or anaphylactic reaction, it is contraindicated. We do recommend that for those patients, especially if you have a febrile illness, that you defer your vaccination until your symptoms resolve. And the vaccine is not routinely recommended in pregnancy. Again, there have been studies that have looked at patients who've received the vaccine during pregnancy. Typically, these women did not know that they were pregnant, and there doesn't appear to be any increase or spike in the risk of birth defects or abnormalities. But again, if you do know you're pregnant, we recommend that you wait until after pregnancy before you receive the HPV vaccine. I think like most vaccines, that there have certainly been lots of headlines about potential safety issues with the HPV vaccine and potential severe reactions in some patients to the HPV vaccine. In general, this is a very safe vaccine. This vaccine, as I'll show you, has now been millions and millions, tens of millions of doses have been administered worldwide of the vaccine, and severe reactions are exceedingly rare. The most common reaction are local reactions. Again, this is an intramuscular injection, typically in the arm. So site infections, so often you will experience some pain, swelling, and redness. Sometimes low-grade fevers you'll experience from the injection, but again, severe reactions are extremely uncommon. This is a report from a reporting system in the United States called the VAERS reporting system that evaluates vaccine efficacy and safety. So this is data back in 2014, where already nearly 70 million doses of HPV vaccine have been administered. And the safety reviews are very much in line for other vaccines that are routinely administered, including tetanus and diphtheria vaccine. And then again, as I showed you, most of the safety reports around the vaccine tend to be local injection site reactions and not severe life-threatening or long-term complications associated with the vaccine. Now, what about the efficacy of the vaccine? As I mentioned, the vaccine was first approved now well over 15 years ago in 2006. So as the vaccine has been rolled out worldwide, we now have kind of the ability to look at the efficacy over time. And again, what we see is hopefully in the near term that this will reduce HPV infection. But the ultimate goal of the HPV vaccine, and this will take time, is that after many, many years, after decades, that the HPV vaccine on the population level will start to have an effect on reducing the rate of cervical cancer. And we are indeed seeing this. This was a study that was published last year. This is a study from England, from the UK, data from London, where they looked at women predominantly, but also boys, and the infection rates overall. And they looked in women at the incidence of cervical cancer based on the age of vaccination. You can see here in the first few bullet points that for women who were vaccinated between age 16 to 18, there was a 34% reduction in the rate of invasive cervical cancer, a 62% reduction for those who were vaccinated at age 14 to 16, and a nearly 90%, an 87% reduction in the incidence of cervical cancer in those women who were vaccinated when they were 12 to 13 years of age. You can see the corresponding reductions in high-grade cervical dysplastic conditions. But again, what we're now seeing with the rollout of this vaccine is that it's at the population level. It appears to be highly efficacious in reducing the burden of cervical cancer in countries that are doing vaccination. Now, what about in the US? How are we doing with vaccination? And what I would say is, not bad overall, but we definitely have areas of improvement. So this is a graph looking at vaccination and looking at percentage of young teenagers who received vaccination from 2013 to 2017. What you can see here is that, in some populations, the rate of vaccination is in the 60s to 70%, but we still have, certainly, under vaccinated populations. Again, we're best at vaccinating urban populations, suburban populations, but we still, in many of these populations, there's still a fair ways to go in vaccination uptake and getting vaccine to boys and girls who are potentially eligible for the vaccine. Again, I think, this is encouraging. When I used to give this talk 10 years ago, these rates were in the 30% consistently across the board. So we've definitely made some progress. But again, there definitely is, some upward room to grow in how often we're vaccinating. Again, this just shows our overall uptake of HPV vaccination over time. What I'll highlight is that, we are, getting better at vaccinating, but again, the recommendations are still that you have at least 2 doses of the vaccination. So the 2016 ACIP recommendation is having at least 2 or 3 doses of vaccine. So you can see that we have a ways to go, and there's also a substantial number of folks who are receiving 1 dose of the vaccine, but don't ultimately follow up for their 2nd or 3rd dose of the vaccine, which is really what you need for maximum efficacy of the vaccine. So again, this is, I think from a public health standpoint, this is an area we could certainly target. This is a preventable cancer, and getting this vaccine out to young, boys and girls, definitely this is a cancer preventing strategy. So I said I would touch on a couple other areas, before we finish. Again, most of what I've talked about is looking at vaccine efficacy of men and women under 26 years of age. Most recently, the vaccine has been approved by the CDC, the Centers for Disease Control and Prevention, up to age 45 in males and females. Now, despite the fact that this vaccine is approved, it's not routinely recommended that people aged 27 to 45 years of age undergo vaccination. And this is purely from a policy standpoint, this is purely due to the fact that by age 27, a large percentage of both men and women have already been exposed to at least 1, often multiple HPV viral types. So the absolute benefit in this population of vaccination is much lower than vaccinating in the 11 to 12-year-old range prior to exposure to HPV. Now, that's not to say that there isn't benefit, and that's not to say that you shouldn't have vaccination in this age range, but what's recommended is shared decision making. So it's essentially weighing the pros and cons of vaccinations between patients and their healthcare provider. What I will say is, a fair number of people who are in this age range will elect to undergo vaccination, but it's not a routine recommendation, overall at the population in the United States. But if you're someone who's in this age range who hasn't been vaccinated, certainly this is something, worth considering and worth talking to your physician or your healthcare provider about. But there are other, I think, what I would call promising, potential areas of using the HPV vaccination. As again, I showed you at the early part of the talk, precancerous conditions of the cervix are relatively common. And what we see with this is often for women who have these precancerous conditions, they often need to undergo what's called an excisional procedure to remove a part of the cervix with these HPV infected cells. And there is now some data that for people who undergo these procedures and you remove all of the precancerous cells, by doing HPV vaccination after one of these procedures, it may decrease your risk of subsequently developing another HPV infection or additional precancerous changes on the cervix. So again, the HPV vaccine is not meant to be therapeutic. It's not meant to treat precancerous conditions, but for those people who have not been vaccinated who develop one of these precancerous conditions, there is some hope that potentially in this population using the HPV vaccine may reduce the risk of recurrence in the near term. So from some other professional societies, so in Korea, this is now something that's routinely recommended, and I think you'll see more about this in the United States overall going forward. So, again, this is, I think, my last slide, so I'll end with this. This is kind of a breakdown looking at HPV vaccination rates, across the United States and broken down by specific states, and I think, again, we're all, used to these types of slides now where there's pretty widespread variation depending on where you live on the uptake of HPV vaccination. But again, I think the take home message is, that we are getting better, but there's still, certainly a lot of room to grow. Hopefully, 5 years from now, we're not going to need to be talking about this, and the uptake of HPV vaccination will be much better, and we'll be, further on our way to eliminating cervical cancer. So with that, I will end. And I really thank everyone, for their time today and coming on this Zoom. I know everyone has busy lives. This is, I think, a topic that's extremely important, again, for all ages. For the risk of developing cervical cancer, for the ability to be able to prevent cervical cancer with the HPV vaccine. And again, my plea for everyone is encourage your family members, your kids, your relatives, to get the HPV vaccine, because this is a cancer vaccine, and cervical cancer is something that we can eliminate, and we can get rid of this disease with the tools we have at hand. So thank you very much, and I would be more than happy to take any questions anyone has. Thank you.
Thank you so much for that, Dr. Wright. I do not see any questions coming in through the chat right now, but we have a smallish group at this point. So I'd feel comfortable if anyone wants to unmute themselves. Feel free to do so to ask your question, or again, the chat box is open. And maybe I'll ask a question while everyone is thinking is, and I apologize if you addressed this, but what if somebody doesn't complete the dosage amount for the HPV vaccine?
Yeah, so a couple points on that. To get the maximum protection for the HPV vaccine, it's recommended that you finish your dosing schedule, either 2 doses for younger patients or 3 doses for everyone else. If you do have an interruption, you don't need to start over, so you don't need to go back to dose 1. You can just pick up where you left off and complete the vaccine series. So again, even by if you have a prolonged break between the first and second and third dose, and you start up again, it does induce a good long-term immune response. So definitely try to stay on time, but even if you can't, finish up and try to complete the series by all means.
Thank you. All right, you might have been just so thorough with everything. That was such a wonderful presentation.
I think there is a question in the chat that just came in. If you've had genital warts in your 20s and pap smears have completed, is there still a chance? Maybe a chance of developing precancerous changes?
That's what I'm thinking.
Yeah, so yes. So if you've had genital warts, again, there are over 200 types of HPV. So the types that cause genital warts are different than the types that cause precancerous changes. So just because you've had warts, and even if the warts have gone away, that doesn't mean you're not going to get a precancerous change. And you still need to undergo screening with pap smears. Now, kind of the flip side of the coin is, just because you've had genital warts, that genital warts in and of themselves don't increase your risk of cervical cancer per se, because it is a different HPV viral type. But definitely, everyone needs to be screened. Even those people who have been vaccinated, even if you've had the HPV vaccine, it's recommended that you continue having Pap tests and screening for cervical cancer, because there are a small number of cervical cancers caused by the HPV viral types that are not a part of the vaccine. So women should continue to get their Pap smears and have their examinations.
Looks like the next question is, are there treatment options at the precancerous stage?
Yeah, so there are definitely, treatment options at the precancerous stage. And the timeline that I've showed you, that time from an HPV infection to the development of cervical cancer is typically well over 10 years. So what we're doing with the Pap smears, we're trying to identify these precancerous changes so we can go in and treat these precancerous changes before they ultimately develop and turn into a cancer. And the treatments we have for that, are also highly efficacious. The most common treatment is what's called an excisional procedure, either a cervical cone or a LEAP procedure, where we essentially shave off or remove the very outer portion of the cervix where these abnormal cells are. We sometimes will also do a procedure called cryotherapy, where we do freezing of the outer portion of the cervix. So these treatments are very effective. So again, women should definitely get their Pap smear. If you have an abnormality, it's important to follow up with the abnormality so you can detect these precancerous changes and so they don't develop into a cervical cancer.
Thank you. Looks like our last question for now is if you can speak to if there are other downsides for getting the vaccine up to age 45.
They're really, the main downsides are the risk of side effects. And again, the side effects tend to be local. So a little bit of transient pain, sometimes a little bit of redness and what we call erythema at the injection site. Sometimes from a practical standpoint, sometimes tend to be a little bit more on the way of insurance issues. So coverage for the HPV vaccine in people who are older than age 27, which there really shouldn't be because this is a vaccine that's approved. But again, you should definitely, talk to your provider. Again, many of the patients that I've seen, after you do kind of weigh the pros and the cons and the potential benefits, even though you're probably not going to get as much benefit as someone who's 11 to 12, for most people, there is some benefit. So many people will elect to go ahead and get the vaccine. So again, it's a discussion to have with your healthcare provider and make an individual decision. But certainly it's reasonable.
Any other questions? Looks like we have another one coming in. Are Pap smears 100% effective in collecting precancerous cells?
Yeah, great question. And the short answer is no. So Pap smear is overall a very good screening test, but it's not perfect. So there are a small amount of cancers that are not detected on Pap smears, particularly cancers that arise not on the outer surface of the cervix, but kind of in the canal of the cervix. Those cancers tend to be, unfortunately, harder to detect on Pap smear. So there is a small risk that if you have a Pap smear, that it can be falsely reassuring. And I think, again, that's why kind of having a dual strategy of vaccination as well as follow up with Pap smears, it's kind of an extra, safety blanket against cervical cancer. So Pap smears, highly effective. Again, if you follow recommendations and get your recommended frequency of Pap smears, but it's unfortunately not 100%.
All right, and Karen is asking, why are parents resistant to having their child vaccinated for HPV?
Yeah, I think it's probably, multiple reasons. I think, and probably the biggest reason, unfortunately, there is some vaccine hesitancy. There is fear about the side effects of vaccines. I think we faced that a lot when the HPV vaccine first came out. I think, we're in a much better place now. I mean, we have 15 plus years. Tens of millions of doses of HPV vaccine have been administered. And what it's been shown is it's a highly effective vaccine and it's associated with very, very few side effects. So I think we are much more reassured about the safety of the vaccine now. Having said that, parents, I think obviously are worried about their kids and they're worried about side effects. I think the second issue is that, people sometimes equate HPV vaccination with this being a sexually transmitted infection, and they don't want to give a vaccine for a sexually transmitted disease. Again, I think, and studies have shown that in general this is not correct, that this will change people's tendency to have intercourse, change sexual behavior, and that really hasn't been shown to be the case. And what I always argue is that this is a cancer vaccine. I mean, that there's nothing else out there that if you get some type of vaccine can prevent nearly 100% of a certain type of cancer. So this is a cancer vaccine. This is a strategy to give a vaccine to your children that could prevent a life-threatening cancer that's very difficult to treat. So again, for those parents, those teenagers, those people who are hesitant, I think it's important to really sit down, talk to your healthcare provider, go through the facts, go through the data around this so people can make an informed decision.
All right, so we're going to finish up with two hopefully quick for you last questions to be respectful of everyone's time. So the first of the last are, does the vaccine efficacy wane over time?
Yeah, it doesn't look like it. When this vaccine was approved, there was concern that we would need to have periodic booster shots. In those initial studies, those patients have now been followed over long periods of time, and it doesn't appear that you need to have any booster shots. That immune response after either 2 to 3 doses appears to be long lasting. So no need for boosters. It appears that the immunity stays relatively robust and strong.
Great. And the last is, are there typical symptoms if one has cervical cancer to be on the lookout for?
Yeah, so probably most commonly now in the US, the way that we detect cervical cancer is if you have an abnormal pap smear before there's symptoms. So you're often asymptomatic. If the cancer does develop, I don't know if you remember the picture, but it typically forms as a mass on the cervix. So the most common symptoms are to have abnormal bleeding. Sometimes you'll have pain, you'll have vaginal discharge. If you're experiencing any of those symptoms, women should definitely get into their healthcare providers so they can have an examination.